All right. We are live.
Yep.
All right.
All right. Hi, I'm Amanda Payne, the founder of Nurses in Tech. We are going to get started in just a couple of minutes. I'm just waiting for some more people to join the live. We are going to be chatting with Miss Rochelle, who is no stranger to any of us. If you're a nurse and you've been on LinkedIn or you've been in the in crowd, you know who Rochelle is. So we get an opportunity to chat with Rochelle. I think this may be like the third.
Fourth.
Okay, I knew
Fourth.
it was one of those third or fourth time. It seems to get better. I consider you to be like one of those monumental pieces in Nurses in Tech. Not as a thing, but like things monumentally happen as it relates in Nurses in Tech. Then you're usually right there at the center of it happening. So as always, I am attempting to navigate technology. So I'm checking to make sure that we are live everywhere that we're supposed to be live, everywhere that I promised we were
All
going to
right.
be.
All right.
So that is what I'm doing. So I am excited to chat with you all about your updates. Of course, I talk to you all the time, so I usually know what's going on. But I'm excited to have you talk to us about all the exciting work you're doing as it relates to. Well, I'll let you tell us in a minute. So I always start these sessions by saying why I picked the person that I picked to be the guest. So I'm not going to do anything. I'm going to be the same as always. I'm going to tell you why Rochelle is not only the guest today, but is very near and dear to my heart as not only a nurse, but as a friend. So Rochelle you are just to me one of the most sweetest, authentic, transparent people anyone could meet. Right? You show up, you get to talking to you get to talk and it's all politically and eloquently correct, right? And you're doing all the terms and you're in the conversation like she's really smart. Like, I don't know if I'm that smart, right? I don't think I'm that smart. But as you go into telling your story and all that you've overcome, why you do what you do, your passion just shines through and it continues to run fluidly through the conversation. So you're not just open and authentic when you're talking about your personal story, but you're open and authentic when you talk about why you do what you do, and your actual story and your work is very heart centered. You don't sway. You don't go up and down. You're not left and right on where you stand and what issues you're trying to address, nor why you're trying to address them and who would be impacted and who would be affected by these changes. So you're a consistent champion. You're not just a cheerleader at the games that have the most eyes and the most views. Doesn't matter if it's one person in the room or 20 people in the room. You show up with the same passion, the same conviction, impacting, demanding, standing for change. And that is why I personally love you. I consider you to be a very dear friend, a very dear colleague. But if I was on my deathbed or I needed some help, I'm sending for Rochelle. I don't care how we're gonna get her, but get her on the phone. phone or something. I want Rochelle to be my advocate. All right. And so I am honored to know you. I am grateful that God let us cross paths. And I'm excited to chat with you today about the topic we're going to talk about. So I'm going to let you take the seat and tell us more about what you want us to know about who you are. Remember, we are recording this podcast live, so it will be viewed and watched after today. So keep your best foot forward. Don't hold anything out. I don't want to have to put you on the red carpet like I had to do Bridget when she did the first one. She was very, very no, I don't know. No, you have to tell all of your business, like all your accomplishments, not to be like self-centered, but you want people to know what work you're doing and why you're doing the work that you're doing.
Mm-hmm. Well, thank you. That's a lot of big shoes to fill there, Amanda. Um, and to the audience, welcome and thank you. My name is Rochelle Prosser. I am the founder of Orchid Healthcare Solutions. That bore out of both my husband and my daughter being diagnosed with cancer at the same time. My daughter was 3 going on 4. My husband was as old as I am now. And I had to choose who was going to get the help from me. And no one should have to be in that situation. Cancer is just hard enough as an equal opportunity offender. And when you have to choose which loved one you're going to help, it takes on a whole different level and life of its own. And I would not wish that upon any enemy. And so, as a healthcare professional, I'm a neurotrauma ICU nurse of 30 years. I often wondered what would other people do had they not had the level of education, the access to healthcare that I did, and I struggled. And so I often say to any audience that I speak to is that because cancer is such an equal opportunity offender, it doesn't matter what political side you stand on, doesn't matter how much money you've got, who you love, who you're with, what you think, it'll take you out if you don't address it and do it appropriately. And I tried at many levels trying to see where that fit would be. As nursing, we're the largest sector of employers, of employment, of employees in any system. And then translating it forward to being an entrepreneur in business and being in tech and looking at healthcare data and science and having that access that patients need to have in ways and manners that they need. And the only way that I truly thought I could make the most impact is in health policy,
Yeah.
because where health policy happens, it affects all of us nationwide. And if we are not dedicated toward that and actually looking at what's being done, don't look at the lip service, look at what's being done in writing and how that affects you. uh, Health policy most affects nursing because it's done at the municipal and state level. That's how we get paid. That's how we get staff. That's how we get identified as having a need. That's how we get capitation on how we are paid, not by capitalism, by need and demand and supply. And so these are the things that keep me up at night, that affect patient care going forward. And so this is what I do now.
Yeah. So you said a lot of big words, right?
Mm-hmm,
You
mm-hmm.
said municipal and state, and we're not here to do a law lesson, but can you break down um
Sure.
just a little bit of what those words mean for those of us nurses that are watching that don't really we're not really versed in the political landscape, but we
Mm-hmm,
want to know more.
mm-hmm. So for those that I made their ears bleed, I apologize. Not trying to do that. So in any profession, there is a governing body that dictates how that profession will be paid and what monies and investments and opportunities are going to be bore out of that profession. And in nursing, unlike any other profession, it is purely driven by the amount of money any state's local and zip code, which is your municipality, what your county makes, what your tax base is done. So the
Wow.
amount of people that live in a county dictates what the pay a nurse will get. within that county, within that local municipality. So when you have those local commissioner offices and races in politics, they're actually talking about what you will be paid and how you will be staffed. Um, Translate that forward on a state level. Uh, there are two ways that a profession can be paid. It can be paid based on supply and demand, which is where a doctor, a physical therapist, occupational therapist, speech therapist, and all of those other social work, all of those other professions will be paid based on supply and demand. So they'll get higher pay based on the need in the community. Nursing, not so fast,
Mm,
because we are part of the overall hospitality and room charge of a hospital. They do not classify us as revenue generating rather than cost burdening a facility. And so we have capitation, meaning a limit, the glass ceiling on how much we could be paid based in any state, which is why in 50 states you can have 50 different levels and values of pay. And it's based off of cost driver rather than revenue, which is capital. And
yeah.
so
By
when
any
we
chance,
have,
I understood
mhm,
all that you just said, but could you give us like maybe, especially for let's say a family dealing with a family member that has cancer, maybe a
sure,
maybe a real life example of why what you just said is detrimental to the profession, as well as detrimental to the patient and the family.
sure. I think in the news there's been a big deal about PBMs and this 340 rule. So I'll explain that. In Medicaid and Medicare, a public hospital has to be and a nonprofit hospital has to set aside funds for the communities that they serve directly in proximity around in a geographical area around the hospital. And so for those that are underprivileged or underserved or vulnerable, they have to provide services to either near free or at free cost, because the federal government and the state then takes that money from the federal government and funds that program through that specific nonprofit hospital. What they've decided to do is roll back eligibility within having access to those funds. During the time of COVID, under the COVID and the Cures Act, it allowed the hospitals to pay for those that had need because COVID was so daunting to deal with.
Right.
By scaling that back, that payment back, some of the hospitals chose to redirect those funds elsewhere out of these 340B programs, which actually paid for pharmacy benefits and extending Medicare benefits to a larger group of people. By scaling that back, they actually, in Florida specifically, added a rule that you had to have a cap on the overall amount a married couple can make for the family. Whereas before it was not identified by that, it was identified under the Adults with Disabilities Act. If you were considered disabled, you then got Medicaid, you were
Yeah.
eligible for Medicaid. And Medicaid, people think, oh, it's just for women and babies. No, Medicaid is for anyone
Yeah.
from age 0 all the way to 64 and a half year of your birth. So think about that. Medicaid is for anyone from age 0 to 64 and a half years old. That's the majority of the country.
Yeah.
And you are allowed to have this or have access to this so that you do not have to go without health care.
Yeah.
And then they changed it so that even though you would otherwise qualify because you had a diagnosis of cancer, you had a diagnosis of a chronic disease, or that you were terminally ill, you would qualify. You would just automatically qualify with that. they took that away by saying you had to have an income driver. And if
Mm,
your income, so you're asking someone who's dying,
yep.
you're asking somebody who is chronically ill and too ill to get out of bed, on paralysis or whatever that's going
Yep.
on with them, saying, one, you have to get a job, and two, you can only make a certain amount of money.
Yep. Yep.
And if you go over a certain amount of money, you can no longer receive Medicaid dollars. So you already are not going to qualify because you can't get a job because you're too ill to get a job. And if you're fortunate to be able to do something from home, you get penalized.
Yeah.
It's really, truly diabolical. So, how does that translate to a cancer patient? So, it's kind of the donut hole, right? Your child or your loved one is too young for Medicare, that would cover the cost. So, they're in the Medicaid realm. Medicaid dollars are already stretched thin as they are. And now you're working. You might be a middle class person. You might have some resources in the bank, but it's not enough to cover your whole care. But you
Right.
need this because you're not working. Now you no longer have access to
Yeah.
that. So, where you would have the medication that you would have had access to at a reduced cost,
Yep.
there's still a cost, but at least reduced. You don't even qualify for that anymore. So
Yep.
now, because you don't have Medicare to reduce that cost or Medicaid to reduce that cost, um, you're paying thousands of dollars out of the pocket just to have a medication that would have been covered under any other insurance. Any other insurance would have covered it 100%. But because you're in Medicaid, you've got to come out of pocket
Yep.
for the whole thing.
Yep.
And we're talking hundreds of thousands of dollars on some of these drugs
Yeah.
and treatments. So if you weren't in the poorhouse before, you're definitely there now. So that is in a nutshell what is going on. And
Yeah.
for the state of Florida, they threw 300,000 people, women, children, off of Medicaid.
Wow.
300,000 people who would be otherwise qualified and had been qualified even before the pandemic. They threw them off of Medicare. It's staggering.
I just am trying to I'm just trying to think about that number. That's a large amount of women and children. I mean, that's not even counting, men that
Yeah, that's not even counting men.
need
Mm-mm.
that need and actually require Medicaid.
Yeah.
So I know that I don't in any way try to associate myself with anyone that has is suffered or is suffering with cancer, but being living with Lyme disease, which I know a lot about. Um,
Mm-hmm.
there are thousands, maybe even millions of people that live in the world with Lyme disease that fall into this very same category,
Yes.
um, and that it's really an endemic, believe it or not, and
Yep.
people don't
Mm-hmm.
really understand what it means. And so I know we didn't come on here to necessarily just talk about Medicaid or Medicare.
Mm-hmm.
And I think there's also a conversation needed to be had around, whether Medicaid and Medicare are still, whether they're Obamacare and whether it's, cursed because it was Obamacare. I think a lot of people that even possibly would qualify don't even look to it to be a solution because, Obamacare, right?
Yeah.
So
Mm-hmm.
that's a whole other conversation, though.
That's a
But
whole other conversation.
now that you've kind of explained to us why, as a nurse, why you've gotten involved. You have your family, your daughter and your husband who have gone through treatment, who you've had to watch and care for and provide for as a provider, but also as a family member. Even your father, you've just been like triple whammied in this situation.
Mm-hmm.
But then you've talked about how, as a nurse, how that's impacted, if it affected you as a nurse. And
Mm-hmm.
now you've kind of broken down some of the political and the economic standpoint of why nurses should care. Tell us a little bit about, first of all, your company. Well, you have
Okay.
yeah. Tell us about Orchid Healthcare. What do you do at Orchid Healthcare, and how did Orchid Healthcare become a living?
Um,
The dog
like,
wants to hear about Orchid too.
yes, my compadre next door. He's chiming in.
Yeah.
So Orchid Healthcare bore out of trying to find an answer where there was no answer. My daughter had an ultra rare disease that was originally thought to be common in children, astrocytoma, but her type of astrocytoma ended up being a mosaic cancer, which there was no proper cure. There was just no treatment available. And so we ended up in the experimental realm for humanitarian use really fast. And because there was no options, being a healthcare provider, it is assumed that you have every answer. It is assumed that you don't need help. There's a lot of assumptions that are wrong. We are caregivers and we suffer just as much, sometimes more than the patient, because we truly want to help and we don't have an answer. And so I didn't have an answer. I'm a neurotrauma ICU nurse of 30 years. My daughter had a brain cancer. Maybe God trained me and got me ready for a situation like this. Forever thankful and grateful. Either way, I needed an answer, and I couldn't share myself physically to help everyone, but I could share what was in my brain and what I knew. So Orchid Healthcare Solutions is a nursing platform that is dedicated to nurses and founded for nurses. It also contains a cancer treatment library that houses all oncolytic therapeutics in one place, all cancer treatments in one place. And soup to nuts, what is out there in experimental realm, all the way to what FDA is approved, and then off-label use to give answers. It removes zip code barriers. It removes formulary barriers that you'll only get the medication that's in your hospital that you chose to go to. It removes all of that. But I truly focus on patients with stage 3 plus or stage 4 plus metastatic disease, like my daughter was, because those patients really have limited choices and they're not aware of what else is out there. And sometimes the physicians are not aware of what's out there as well. And at that time, you're not looking for a cure. You're just looking for an option. And that's what I'm trying to give you. So that's Orchid Healthcare Solutions.
Well, I'm always overwhelmed when I talk to you. So tell us about the cancer treatment library. I know you said it houses all the medical things we need to know. Break it. I got to ask you to break it down for us like I'm a third grader.
All right. So what it does is it teaches you what the drugs are, what it's used for, what are the other uses that it's for, and can it be used in other drug combinations? It that might help you. So if you have cancer in one location, you can look for that one location, and that drug may come up. But what if you have your cancer in multiple locations, 2 or more locations? You've got lymphoma and you have lung nodules and you have prostate cancer. Well, that you can look there and see if there's other drugs or other treatments. Maybe it's radiation, maybe it's using sound, and it might be able to help you. If your tumors are too big for extraction, if your tumors are too big for traditional without surgery, and you don't want to have surgery, well, there is this thing called sound using an MRI or a CT scan or an ultrasound wand that can actually break it up, and it's proven it works. There are companies that do this. This helps you find where they are. So basically, we're giving you the option to be treated in the way and manner that you choose. If you don't want to do chemo, it might be an immune therapy that you might want to do. If you can't swallow pills, well, then we'll go to chemo or radiation or something else. But the most important thing is when you have knowledge and that is tied to access to care, you can change the bulk of your circumstances. Maybe that's not what you want to do, but at least you have the ability to have that informed choice on what you're going to do. And that's what we offer.
So the cancer treatment library, let's start with patients and families. Can they access this?
Yes.
Okay.
Yes.
So Yep. Okay. So I'm a mother, and I have a child. How would I access the library, or how would I get access to you, and why would I want to get access to you or your cancer treatment library?
Right. You would go to orchidcancercare.com and register. On that registration page, it it's going to ask you a series of questions. One, I need to verify who you are.
Okay. Uh-oh.
Okay, there we go. We're back.
There you go.
You're not only going to get access to the cancer treatment library, you're going to get access to me. And
Okay.
I provide healthcare systems navigation. I'm going to sit and talk to you to find out, where are you stuck? Because people usually come to me because the treatment isn't working. They're having their maybe their provider isn't listening, or maybe they're not receiving the treatment in the way or manner that they want to be treated. And so they're coming to someone like me, an oncology nurse navigator, to say, I need help. I need
Okay.
help. I'm stuck here. And so we'll find out where you're stuck, put a plan together to get you unstuck. But here's the difference: I'm going to work with your healthcare provider and let them know what's going on and have that conversation to get things back on track with you. I don't offer to be a cure, it is a service. It
Yeah.
is using my expertise to help you find a path or get to a consensus of where it's okay. Sometimes there's a lack of education and a lack of
Yeah.
communication. And that disconnect breeds a lot of misunderstanding and mistrust. And at the end of the day, I want you to be able to trust the process and trust being within the healthcare system, because that dignity piece, that trust piece is
Yep.
woefully inadequate and missing. And so, at any point where we can bring people together to move forward in the best possible path for a patient, that's what I'm about.
Yeah, yeah. So I put your website in the comments, so it'll go to all the channels. So I'm a nurse, and
Mm-hmm.
I'm just, I've been working in oncology. Maybe I've been a travel nurse and I floated to different areas. I worked in oncology several times, many
Mm-hmm.
years actually, as a travel nurse before ever being affected. So as I said, with Lyme disease. It's Lyme disease, but I spent a lot of years in the oncology hematology department because nobody knew what to do with me. So
Right.
a lot of patients, deal with a lot of patients as a patient, but also as a nurse,
Mm-hmm.
that were trying to understand and just, they did what they had to do on their jobs every day to care for their patients, but always may have this yearning to just do more.
Mm-hmm.
How can the cancer treatment library help me, or how can Orchid Healthcare help me if that is one of my
Mm-hmm.
yearnings, to learn more, to do
Yes.
more, to be more of a resource?
Mm-hmm.
How does cancer treatment library help me do that?
All right. So I built that as a nursing EHR. And if you've seen EHRs lately, they're built for physicians. And there has been a few muterations and iterations of people attempting to build nursing platforms or nursing EHRs, but it's always focused on the physician. It's never actually focused on the nurse. One, teaching the nurse business acumen,
Yeah.
how to earn money, how to understand how to bill for their services, understand what codes they can bill for. There's a bee flying around. Understand what codes they can bill for and what they cannot bill for. Teaching them the reimbursement model that is current today for CMS and for the insurance company, how to even fill out an invoice, how to build a consulting agency, because you're working independently. Nurses can work independently, especially in some areas in the Midwest where there isn't anybody but the nurse.
Right.
And how to make yourself financially solvent while working within your profession. That takes learning. It is not something that they train you in school. They don't even train doctors to do that. You have to learn how to do that. So
Yeah.
this platform is built for you to do that, to teach you how to send an invoice. It actually is automated for you. You just need to put in who your client list is or your patients. It will show you what you've made and earned over time. It'll show all of that to you. So, yes, I start with oncology. Why? Because the oncology codes are the only codes that a nurse is allowed to reimburse under. It's $22.95 out of the overarching payment of $209 that you would share 90/10 with a physician. But if you're an independent practice nurse, you actually can bill that to CMS.
Okay.
Some insurance companies are still on the fence about it. They want to make sure that you want to use principal investigator codes, meaning that you're tied to the physician. But there are actual ones that, and in certain states like Florida and I think Oklahoma, allows the nurse to bill for podiatry services. And so the field of nursing is changing because
Yeah.
the landscape of healthcare is changing. We
Yep.
have a workforce shortage. And we also know that um, by empowering nurses, and you young millennials and Gen Zers are not having it. You're just not having it. You will say, this is not for me. I'm going to go and be an entrepreneur. So
Yep.
for all of those that want to do that, there is a place for you to land and
Yep.
build your business in the right way with all the tools and supports available. And that is Orchid Healthcare Solutions.
You're certainly right. Millennials, Gen Xers, or Zers, or whatever they call them. Yeah, we're a
Mm-hmm.
little bit we're a little quicker to be like, nah, I'm not gonna do that.
Mm-hmm.
But even with that, so I understand what you said, and you said a lot, and it all makes sense. You mentioned a couple things. You said CMS. So first of all,
Yes.
you said nurses. You said the codes that nurses can be reimbursed for.
Mm-hmm.
All right. Tell me like I'm a third grader again.
So, under the standards of practice for oncology care nursing, these were put out in 2009 to say how an oncology care nurse or a nurse navigator can provide care under patient advocacy, under oncology care navigation, or being a nurse working with patients navigating their care under social worker, or just being an agent for an individual as a liaison. You can provide navigation codes. And
Okay.
as of January 1st, 2024, that nurse under that standard is allowed to bill the Center for Medicare and Medicaid for her services independent of a physician, as long as she's not billing the principal investigation codes. So, principal investigation is saying, I'm taking the lead, I'm generating orders, and I'm telling you what to do,
Gotcha.
right? As long as you're not doing those, the rest of the code set you're allowed to do for transition of care, for navigation, care navigation. It's usually under the 99284 or along that lines, but there are specific codes out there, and reach out to me. I'm happy to share.
Yep.
Um,
Sounds like to me
and
you're saying that nurses have an ability to be reimbursed for
correct,
the care they provide. They need to get educated on what those codes are and what services they can provide based on what
correct.
state they're in. But
Mm-hmm.
I think I heard you saying that it's important to like understand politically what's happening because there might be some freedom for nurses to cut out all the top men and the middlemen and go right to the patients. I think that's what I kind
Correct.
of mean. You know me, I like to
That is
break, I
correct.
like to cut through all the,
Yes,
move all the
that's
stuff
what.
out the way and let me get straight to the point. So you're telling
Mm-hmm.
me
Mm-hmm.
that one reason that I should be involved or at least understand the political landscape along with the economic landscape is because there are things preventing me from being able to have the full freedom as a nurse to operate at the height of my license in helping patients because that's what every nurse, why did you become a nurse? I just want to help people.
No,
I just
we
want to help
deserve
people.
to be valued and paid.
Yes.
We deserve to be valued and paid, and we are the only profession that is paid in this way as a cost driver, as a capitation, meaning
And the
that we have a limit
hospitality
of
on top
speaking.
of that. Hospitality.
And under hospitality, yes,
Hospitality.
and
Aren't those
there,
like the people that work in the hotel industry and like
correct, yes, because so we have to look at the myths of nursing, right?
Oh,
Florence
please, let's
Nightingale.
look at them.
Let's get all in there. Florence Nightingale was a statistician and a mathematical major, just
Yep.
like her father. But at the time, women were not allowed to be educated, or at least allowed to go to school for that level of education, way back when she was running around. The Crimean War posed an opportunity for her to look statistically on the law of averages of survival, looking at the cleanliness of the environment.
Okay.
What she noticed was, over the field there was this green slime that was antibiotics, penicillin, but also if you open the windows, the penicillin went in to
Yeah.
the room, right? If you're looking at microbial transfer. But you also let out the microbials that were bad and causing sepsis, right? But just by cleaning the surfaces,
Yep.
including the wounds, and letting air get to it. The men of the day looked at it, oh, she's a cleaning lady. And she walks around with the lamp of the light. And I don't know if you hear some music, night nurse, all of these things where they contextualize, they sexualize, and all of the other isings
Yes.
of nursing rather than seeing it as a science and a
Yes.
profession.
Yeah.
And here's the final nail in the coffin. Nursing is not seen as a science.
No. Oh, no.
The when you're learning, even though it sits under applied sciences and under the College of Science, and when you get your bachelor's degree, it's a Bachelor of Nursing in
Science.
Science. The actual profession itself is not classified as a
Nope.
science. And therefore, because we don't have that classification, we do not grant funding or research dollars or any reimbursement or honorarium or acknowledgement of what we do scientifically at the bedside, which is data collection,
Yep.
data analysis, compiling of patient reported outcomes, and actionable care plans.
Yep.
So when you look at it historically to where we are today, and when we have certain administrations that care, that want to advance healthcare,
The science.
we we have these politically advances where we open up the opportunities for nurses to be able to be autonomous professionals. Just like way back in the 80s, we were able to do nursing diagnoses. For us older nurses, seasoned nurses, whichever way you want to call me, I'm a Gen Xer, nurses, we were writing nursing diagnoses based on our profession.
Yeah.
It is quite different. And it were based on those pesky social determinants of health that we talk about today, that now nobody can address, that nobody can find, but have been around since every census, since the onset of 1921, I would believe. But yes, we were looking at and addressing those social determinants of health and health equity in healthcare way
Yeah.
back then. And
Yeah.
we actually had things called HCPC codes, health cost codes that went according to those diagnoses that were somewhat reimbursed, but the hospital had reimbursement.
Yeah.
Then what they did was lump us all into the room charge, and under the room charge, it's a specific code 23XX or 22XX under revenue codes. But the only revenue codes that are reimbursable is for the hospital. So now that removed direct payment that was line item in the hospital bill that said nursing care. It
Yeah.
rolled it up into the room charge, and now we stop being independent billers. Hi, hi,
Hey
Tina.
guys.
So you
And
joined at the most amazing time. We are talking about health equity. So who
Oh,
better to join the
amazing.
conversation about health equity than this equity queen?
Love that. I got to get that on a badge.
I mean, when I hear health equity, I'm like, where's the stuff? That ain't my wheelhouse, but I know somebody that can talk to us about health equity. So You can jump in wherever you want. It's so wonderful to see your face. I feel like we are like having like a real selfish like kumbaya right now because it's like, where have y'all been? I missed y'all.
A reunion, yeah. I didn't even know that y'all were doing this, and then LinkedIn popped up, and there you were, and I was like, oh, I have to join this.
Yeah, I got to do better. So Tasaya is in Spain. Although she has moved to Spain with her son, and hopefully I can get her to do a podcast for us in the next week or two. But we're just talking to Rochelle. We're talking a lot about, mainly the focus is about the work she does in the political landscape, to begin to shift and transition the way healthcare as it relates to oncology, but not just oncology. Like, why should nurses even care? Because especially with the election coming up, you either have nurses as well as people. We're all nurses. We're a nurse group, so we're talking about nurses, right? But this could be applied to anybody. We see this, especially after the debate. You either see people like throwing their hands up, like I don't got nothing to do with this. I don't want to be a part of this. I'm just gonna put my head in the sand and act like it ain't happening. Or you have the reverse where people are all on like whoever they're voting for. Their mind can't be changed. They've grabbed whatever they think to be true of whatever candidate. And that's all good and great. But as nurses, policy, we can try to change things one-on-one, but nothing changes if policy doesn't change. So we have to have at least the elementary understanding of the political landscape and understand why it affects us. And so Rochelle is here breaking down her journey, her life's work, and educating us like we're third graders on why it's important, because she has to educate me like I'm a third grader, because I can't keep up. So she just did a whole history on Florence Nightingale. We're just talking about, how nursing reimbursement, which this is considered part of the hospitality, the room charge, and all the things. So you went all the way back to Florence Nightingale, and I'm like, golly, I forgot how that's like 18 something. 18, and so I guess my next question to you, Rochelle, is what is the holdup? What can nurses do? So we have like 15 minutes. I know I want to spend some time kind of just you telling us, right? What can every nurse be doing, right? Mm-hmm. I don't care what race you are. I don't care how long you've been a nurse. I don't care what age you are. I don't care what sector you work in, right? If you are a nurse and if you've gone to school and you graduated and you got a license, I don't care if you're retired, if you're not using your license, whatever it is, you're still a nurse.
Yep. Mm-hmm.
You're still a nurse, right? Mm-hmm. So what should nurses be looking toward or begin to look toward to start to understand this landscape? What can we do? I don't know what's going on. I don't know where to get started. How can I get started?
So someone heard me talking somewhere at some cancer symposium somewhere and nominated me to serve on the Health Information Technology Advisory Council. And on there, I serve to protect the patients across the nation from having their data and health information misused, or whether intentionally or unintentionally. Yeah. When we create certain digital technology or when we create the coding that is behind the scenes that runs the digital or medical device that we're using and asking patients to use. Someone nominated me for that. And I was like, why would I ever be here? And then they started talking about these pesky little rules and coding, and saying that, everybody should have the right to have everyone's data. It should be totally accessible, and we just need to have the right terms, and then it should be shared by all. And I'm like, actually, no, not everything should be shared, and it should be by patient's preference. But most importantly, the patient should have the right and access to everything, not everybody else. If you live in a certain state, some things having access to you might put you in jail, depending on what they're trying to look at. And that's a very unfortunate situation and place to be in women's health, but that is actually where we are. And because there's a lack of understanding just a general lack of understanding of what women's bodies do other than procreation, um, that's where nurses can be. Nurses are the ones that are closest to the patients. Nurses are the ones that activate the alert system if something's going wrong with them. They are the pulse of the patient's nation. And we are the ones that do the education when you come into our services, healthcare, and we are the ones that do the education when you leave it to go home. We are the ones that come into your home and provide care to you. So who better than nurses to say, okay, if we really want to adopt change in healthcare, come to us. We understand it best. We should at least, if not drive the conversation, at least be at the table.
Yeah.
And that is where we're lacking. Unless you have a bunch of alphabet soup letters behind your name, you're not going to get there. And
well,
so
I don't know if that's helpful either, because I know a lot of nurses that got a whole lot of alphabets behind their name and they ain't at the table. So I'm wondering, if you want to throw. I know you do some work, not as much work like at the political level, but I know that you have a lot of insight, and maybe you want to throw something in. Like what I'm going to tell you guys what I think we should do after you guys answer this question.
I can't wait.
Yeah, I mean, I appreciate everything you're saying, Rochelle. I always cringe when I hear folks say that healthcare isn't political. And I think that, you know, I'm a women's health nurse practitioner, and so it is like highly political. And when I was running virtual care teams across the US for a femtech company, like we had to think really critically about what even our providers were allowed to put in the chart so that the providers wouldn't get into legal trouble. And that's because of the political landscape in our country. And so I think like it affects our ability to provide care. It affects patients' ability to seek care or fear around seeking care. And so I think that in the same way, in the same way that we've kind of like normalized nurses needing to know anatomy and physiology, like you're not going to do your job without knowing anatomy and physiology. I think that we need to normalize being able to understand the political kind of nest that is the US healthcare system. We need to normalize having to understand those policies that affect our practice, because they do all the time and they're constantly changing, and they're a little bit confusing by design to leave people out of it. And so I think it is in some part like nursing education programs' responsibility to be weaving in these points, these like being able to kind of tease out like what are the things, how do you get involved, and demystify it a little bit, because I think it feels really scary for folks. They're like, oh, that's not my lane, that's not my problem, but it's like, but it is. Like you're encountering that every single day.
Well, here's the thing. You have people that say, the mantra is when you go into nursing, I want to help, I want to do something. Well, that's true. But you also want to be valued. You also want to be paid. You also understand that you did many years of education at every level, just like any other profession. And so you should be remunerated appropriately. And yes, it is political. What we do is political. The politics of the lands is like Plymouth Rock in nursing. And we can either be participants in the delivery of health policy, or we can be the food to be eaten. And I refuse to be somebody's meal.
Yeah. Well, the reality is we are participants whether we want to be or not. So
yeah. Yep. And so you can
we're either willing participants or we're just ignorant participants, but we're still participants.
Well, in a lot of ways, it feels like nurses become pawns. Like we're not even full participants, we're pawns. And I think I see this a lot with the evolving conversations around AI and the integration of AI into healthcare. Like a lot of times it's the like narrative is like, oh, it will help nurses, it will help the nursing shortage, it will like whatever. They say things like that and kind of use evoke the like name of nurses as like the solve, but they don't really talk about or include nurses in those policies where like we have the most we stand in a lot of ways like next to the patient as a person that has the most to lose with this situation with
Exactly.
AI, right? And like we see it come in with the equity conversation. Like if you're putting in data, to your point, Rochelle, about data, if you're putting the data that is collected and curated by people who have biases into AI, then you're creating AI with biases. And that's just
Exactly.
gonna keep like a
And
loop
that's
coming
just the way it
back.
is.
And that's the way it
Yeah.
is.
And that's the way it is. AI simply looks at patterns in care, where a human being will say, well, I don't like that pattern, so I'm going to remove it. AI does not have that level of specificity. It only looks to patterns. So you have to look to our society as how we build, or how our institutions are built, how our past behaviors are built. It looks to those patterns. And no matter what we do to carve that part out, a really judicious AI builder will remove that. But where do you have it where the population is doesn't have the language to say that this is what's going on? Like children, there is no capability. So of course AI does not work in there because children don't speak in that way, and they don't have the capability of the language to recreate that. It becomes punitive when you don't understand the culture and are using just terms. And again, it goes to patterns. It goes to
Yeah.
patterns. So it's very easy to create something unintentionally that would cause profound harm. And so the nurses can stand in the balance to say, hey, great idea, but we need to rethink how it's done.
Mhm.
Yeah.
Yeah.
Yeah. So,
And this is, mhm.
no, go ahead.
And the most important thing is nursing has the ability to make that change and get it done. That's the whole purpose of why we're on this call today. I wear a shirt saying nursing is a work of heart, but it's more than a work of heart.
Yeah.
You got to be intentional about what you're doing in looking at health policy and how it translates to the common person, including you, the nurse.
Yeah. Yeah. So I agree 100% with everything you guys have said. I have a very outlandish, just outlandish
Oh Lord, give it to me! I
process.
can't wait.
I mean, we just have to be honest about the situation. I mean, this is not just in nursing, but just general in period. The reality is nurses have to get up and actually go do some fighting. Right? We tend to want to stay away from confrontation. We tend to want to ruffle feathers. We just want to, be free and be happy and help people. That's all we want to do. And our heads are kind of in the sand. Right? We just
I think
kind of
that's
do it.
maybe why sometimes I don't fit completely into some nursing spaces, because I'm like, y'all, get your heads out of the sand. Like we have work to do.
Yeah, we have work to do.
And so the reality is, it is true. I actually disagree. I don't believe that you have to have a lot of letters behind your name to get on boards.
No.
I don't believe that you have to have a doctorate, training to have a view that matters, because the reality is every nurse has a view that matters, because if you're a nurse and you work with patients and families, you have a view that matters. Every nurse that has gone to nursing school, completed nursing school, taken your test, your NCLEX, obtained your license, you have a view that matters. There are different specs on the spectrum of nursing and patient care that every nurse has a view into, and it's needed. It's needed because it's been discounted for so long. Literally, the healthcare system is built on the views and perceptions and selfishness and greed of doctors. Pretty bold statement.
Amanda's just going in.
But it's so very true.
I would
putting
say
an olive branch there.
I would
putting an olive branch. Hold on, putting an olive branch.
This is what I'm saying. The reason I say it like that is
allies,
because the majority of policy and law is dictated by doctors. That we cannot dispute.
Well, the American Medical Association, right? Because I think that's an important distinction. Like, I don't really have any qualms with or any issues with any particular physician. I mean, some physicians, but not any particular physicians, in the same way that I do with certain nurses, but not other nurses. but the American Medical Association has been horrible for our healthcare system.
So as much as you guys felt the need to try to have to fix that up, it doesn't change what I said. I didn't mention any doctor. I
said what I said.
Right? It still does not change what I said. It doesn't. I didn't point a finger. I don't have a qualm with a doctor. I love my doctor. She's amazing. And I'm not talking about a doctor, but we're talking about, when we talk about policy, we're talking about systems. We're not talking about people.
Okay,
policy,
so
the system should be built for people.
If a nurse isn't at the table to say a contrary view or a different point of view, how do you then blame the doctors for all of that, where they are standing up in a vacuum that we are not there? So let me let's
do some clarifying, because I didn't actually place blame anywhere. I said the system is built on, and it is the healthcare system, the policies currently in place, right?
Yes. Okay. Say that the policy is currently in place. Let's.
Well, that is what I said. I said that. I said
so.
And
so that I don't get thrown off of my seat.
Yeah, no, I mean, so we're talking about policy, and we're still talking about policy. The systems are still built on the medical profession's input. Period. I mean, that's true.
True.
I mean, I'm not talking about. I mean, you guys got scared, but I know what I meant. What I said, I still know what I'm saying. It's true. And the reason that's important is because when we understand that way back when, there was a perception like you said, started with Florence Nightingale, where nurses were looked at a certain way. It never changed.
But now
that we know that, and as a profession, we have lived and we have experiences, it's up to us to change that. Remember, my question was, what is your suggestions for nurses to get involved? We went all around the conversation about boards and being in the room and da-da-da-da. And then you said, you got to have letters, but the reality is you don't need any of that to be encouraged.
You just need to participate.
Well,
your voice matters. Serve on a board. Even if you don't know what you're doing, get on the board, because it's going to come to a point in time that they're going to talk about something that it pertains to nursing, and you will be able to put your 2 cents into the mix. That conversation.
We got 15 cents.
Serve on a local municipal council. Serve on your school board. Serve in your local senator's office. Hell, run for something.
The reality is you just need to start serving, and that is where I was going.
Service, public service.
That's where I was going. I know you guys thought I was getting ready to go down some way.
There's an organization called Healing Politics.
You guys
talked about that already? Okay.
Yes, that's a great start. Or even Emily's list.
Well, there's also an organization that I'm not going to put here, but there is an organization called Nurses on Boards Coalition. That when I was in nursing school, we were told to reach out to them. And I haven't reached out to them, but I've done a lot of political work here in Indy. But there are ways for nurses, and that's where I was going with this. At this point, it's no longer like we weren't invited to the table. At this point, it's you find your table and you get to it.
Yep, I agree.
That's the reality. That's the truth of the matter. See, y'all thought I was getting ready to go rampant on somebody, and I was not. Listen.
Rochelle's like, I got a seat to hold. I'm like, I run an interdisciplinary community. Like, I got physicians now texting me.
I mean, well, this is the thing. I think that's where we as nurses, we have to be strong in what we know. This is not my opinion. This is a truth.
Yeah. Okay. So if we were really to go through it, people, way back when hospitals were first born, people didn't go to the hospital because they went for the nursing care. They didn't go to the hospital because, doctors didn't practice cleanly surgeries and they didn't wash their hands. And so people went there. It was a last resort care because you couldn't afford the nurse in your community to take care of you, even if it was to barter something. And so coming through the years and after the Depression, when they actually started putting out managed care in terms of, okay, Center for Medicare and Medicaid, way back in the 1930s. This is where the change of what the profession of nursing being classified got solidified into health policy, in that we are rolled up into a room charge in a hospital. And so we have to look at it from its historical context of where we've started, what got us there, and now what do we need to do to change that. And so I encourage everyone, run for something, speak up for something, join a business entity and serve on a board. That way, nursing can be involved in the care delivery and the building up of technology, of services, of policies that affects us generally, but at least we have a voice and are seen as a stakeholder. The tables are there. We just need to be present at them. Do not be faint of heart.
Right. And so I know it may sound like we're going tit for tat right now, but
we're not.
You keep going back to my point. See, history is important and facts are important. And you just gave me, I know that, but I didn't say it. But listen, people could not afford the nurses because nurses were independent providers providing top-notch care.
Mm-hmm.
Are we gonna talk about like granny midwives and how the industrial complex pushed out Black women from serving our own community?
Well, we can schedule we can do another one and talk about that. But I want to wrap up where what I really was pushing to get to is that as nurses, we have to understand that it's about our mindset and how we view ourselves. It's important for us to understand how the policies got in place and why the policies are what they are. So that way nurses don't internally feel like I'm not enough. It's not that you're not enough. It's not a reflection of you at all. This is how the policies and the system became what they are. It had nothing directly to do with you at all. As a matter of fact, as a nurse, you have way more power, right, than you think you have. You just don't know how to utilize the power. And that is what I'm trying to get to. That's what the point of why I said, if nurses understood that the healthcare policies are not created, nor is the voices at the table are not nurses, they're medical professionals, they're doctors, then nurses would feel like, oh, okay, it's not as if they're just trying to mistreat me. They don't know, they don't know what I know. So it's not like they're trying to mistreat me. She's dropped off a couple times and I know we're over anyway. But I would love to have the conversation, Tasaya. You look, you are like, I swear you are the equity, justice, health.
Yeah, because I'm over here being like, Florence Nightingale was racist and I want to talk about it.
On that note, we're going to, you don't have to get off, but I am going to stop the recording at this point, right? And I appreciate, hopefully Rochelle can get back on. If you're viewing this to the end of the recording, so for an hour and 2 minutes, I posted some links in the comments. If you want to reach Rochelle, you want to reach Tasaya, if you want to reach me, you can easily find me. We thank you for joining and we look forward to chatting with you again next week. Oh, I didn't mean to do that. Okay, here we go. All right. So I'm